afternoon, everybody. Hello, Andy. It's lovely to see Dr. Andrew Yeoman from South Wales, Cardiff, I think he works. And he's one of our medical advisory board. And it's lovely to have him here. Thank you, everybody, for your questions. I'm Collette, by the way. I'm Collette Thain on the good days and just the Harridan on the bad days. But we'll answer as much of your questions as possible. I would like to say at the outset that, you know, we can make personal comments about your own personal care or your personal PBC. It's not right to do so for yourself because we wouldn't have full information, and our medical advisory board cannot give out advice when they don't have a full picture, and that's really not what they're here to do. They're here to answer general questions about PBC, and if you want, you can come back and ask some more, but that's the idea, because there's an awful lot of people out there who don't know an awful lot about PBC. So that's what we aim to change. Is that fair, Andy?
Absolutely fair. Absolutely fair.
Okay. So are you ready?
I'm ready.
Okay, right. So this woman, it says, hi, I'm newly diagnosed, 51 years old, and been on Urso for a month. I hear people talk about having itch problems, and though I was lucky not to have this, however, my eyes itch terribly on my eyelids and the corners of my eyes. My GP gave me hydrocortisone cream and pharmacist eczema cream. Neither work. I now wonder if this is the itch. What do you think?
Yeah, it's a very unusual location for itching without having it elsewhere in your body. And so I would say that would experiencing itch, it's less likely to be PBC related, but there are some other things in that sort of area of the body where people with PBC can get problems. I'm thinking particularly sometimes it can be associated with a condition called Sjogren's, where you don't produce enough tears, and so that can leave the eyes feeling a little bit gritty, and that can make them feel itchy, or you know, constant need to try and rub them to try and get those tears flowing, to try and get rid of that sort of gritty sensation that people can get. But also, it sounds like if the GPs use some hydrocortisone or steroid creams, sometimes people can get eczema or other reactions around the eyelids. So if it's a specific skin reaction, it might just be that there is indeed some eczema around there. But if you are experiencing dry eyes, it would be worthwhile popping back to your GP to get that checked over. And they might need to do a formal assessment to see if you're producing enough tears, because they can use some drops to try and help with any of that grittiness that people can experience. So I would never say never, because I've been looking after people with liver disease and PBC for a long time now, and there are very few absolutes, aren't there, Collette? You know, and people can have strange manifestations of common problems, but certainly to only have itching around the eyes would be extraordinarily unusual. So I think the GP is doing the right thing to consider other causes that are not related to PBC.
Could I add to that, please, Andy? And I make it clear to everybody, I am not a doctor. I am a law accountant. I'm a fraud specialist. I know nothing about medicine, but I do know little bits. I've been in this game for 30 years. Now, Sjogren's, as Andy was alluding to, is dry eye syndrome. And just to explain, we have two sets of tears in our eyes. And one set of tears, you know, when you go out in the wind or whatever, you know, the water. And or when you cry, the water. But the other set of tears, unknown to you, every time you blink, there's fluid that just covers your eye and keeps it clean. And it's that set of tears that appears to be missing, disappear, depleted when you suffer from this thing called Sjogren's syndrome or dry eye syndrome. And it's relatively common with people in PBC. And some would say that it's a benign condition, but I'm not convinced I would say that. But what can be helpful is oil-based drops. So it's worth popping into Boots do opticians. They have opticians these days. It's worth popping in. Yes, go back to GP, absolutely. But an oil-based drop, just to see if you can get that bit of extra fluid in your eye, to see if that might help. Is that reasonable, Andy?
You don't need me. I can go now. So that's.
No, don't come back. We love you. No, I don't want to say anything that's.
Absolutely, no, that's absolutely right. So I think an additional lubricant is what's needed if there is Sjogren's and dry eyes, and so So that's absolutely right. So I think, and they say you can get those things over the counter because there can be delays with getting back to the GP, and you're not going to do any harm by lubricating the eye a little bit more. Okay, it's not going to be dangerous for you. It's not going to detract anything else.
And also, I mean, some of us women, no, not many, she lied, we wear makeup, and you don't know if you've maybe all of a sudden developed a bit of a problem with the mascara. Maybe the ingredients have been changed, it doesn't suit you anymore. So there's a number of things to think about. But I'd like to hear from you again and let me know how you get on, because any tips you have, we can pass on to other people, which is really helpful. So next we're saying, so what is the latest drug treatment recommended for diagnosed osteoporosis with PBC? Stable and blood results now normal with ursofolk. So the latest drug treatment for osteoporosis, well, there's quite a few depending on the level, isn't there, Andy?
Yeah, you're absolutely right. And I wouldn't profess to be an expert in bone health management, but as you've alluded to, there's lots of different types of drugs. So initially, we will often, in some people, we will recommend just some calcium and vitamin D supplementation. So Calcichew is probably the best known brand of that, but there are others available. That's a sort of very entry level. That's just to increase your calcium intake so your bones have more to work with. Some people then take drugs called bisphosphonates, which are drugs which block the breakdown of calcium within the bones and can increase the strengthening of those bones over a long period of time. And those are sometimes given orally once a week. If you're on those medications, you will recognize them because you're told you've got to stand up, you've got to drink a glass of water, don't take out the medications for a while. And it's only taken once a week. So it tends to sort of stand out. You'll know about it if you're on it. Occasionally, those drugs, those bisphosphonates, are given intravenously if people can't absorb them for other reasons. And there are other therapies which increase bone health. Tizapatide is the commonest one. And there's some others recently up, and there's also these monoclonal antibodies, which are these very fancy chemicals which target certain chemical pathways. Those tend to be subcutaneous injections, which are given, I think, usually once weekly. But those are usually directed by usually a rheumatologist, actually, or a bone health specialist. So in some centres, that might be under the auspices of a care of the elderly department. Not that everybody who needs them is older, but actually because osteoporosis is so common in the older age group in many hospitals, these sorts of bone health clinics are run by gerontologists, but it might be run by the rheumatologist. So what happens when you have a bone density scan? There's a clinical team there that in your local area that takes responsibility for reporting those scans and for making recommendations. And they ask for information from the referring doctor. So they'll ask about whether you're on calcium, whether you're on bisphosphonates already, whether you're on other drugs for this. Are you on steroids that make you lose bone, for example? Do you undertake weight-bearing exercise? Do you smoke? And then they'll usually give a report at the end of that with some recommendations. And so if people have failed, in other words, their bones are getting thinner despite treatments with calcium and the bisphosphonates, which are the oral tablets, then patients will, at the request or at the recommendation of those services, will be recommended different drugs, either the monoclonal antibodies or the tizapatide.
And it's worth bearing in mind, there does seem to be a whole plethora of things for osteoporosis now, which is really fantastic because it's a horrible illness. But, to keep up your weight-bearing exercise and to be mindful of your diet as well, because, people like me, I don't take milk and what have you, and I've got a bit of a row for it. But there is calcium in lots of other foods. So have a look online, bread and various things. You'd be quite surprised. So keep an eye on that too, as well as taking the medication. But they really are. They've come a long way, I think, Andy, with osteoporosis.
Oh, phenomenally so. And I think some of the bisphosphonate oral drugs, which for decades were really the mainstay of treatment, can actually, in some people, cause paradoxical fractures after you've been on them for a number of years, because it makes the bones a bit stronger, but they're not normal. So that the bones can be, even though it's building more calcium and more bone, it's not actually always organized in the right way. And so occasionally people can get sort of atypical fractures, or you can get necrosis of the jaw. It's pretty rare. But I think these new agents, as you said, these new developments for people with difficult to treat the process, often go on to the injectable therapies, and those can be fantastically effective for those. as well.
Yeah, and being of that age, my friends are that age, I've heard really good things. It's quite heartening, actually, because getting older is not for the faint-hearted. You don't know yet, but trust me. Now, is common bile duct dilation frequently found in PBC patients? I don't know what that is.
Yeah, so it shouldn't be a feature of PBC in itself. So common bile duct dilatation is essentially saying that the common bile duct is formed from the confluence of the left and right intrahepatic bile ducts. In other words, the ducts that drain the right and the left of the liver come down, join into a common duct called the common bile duct, and then that drains down a common hepatic duct first, common bile duct, into the intestine. So it usually implies that something is blocking the flow at the very bottom of that duct. Now, PBC is a condition that does affect the bile ducts, but it affects the microscopic bile ducts, so that we can only see that typically under the microscope. PSC, for example, or primary sclerosing cholangitis, can quite commonly be associated with common bile duct dilatation or narrowings. But in PBC, we wouldn't expect to see a dilated common bile duct. There are lots of reasons not related to PBC and not related to PSC that can cause that. Bile duct stones, and we know that people with PBC are more likely to have gallstones than the general population. Sometimes if one of those gets stuck in the duct, that can make it swell a little bit. If you've had your gallbladder removed previously, that makes the duct a little bit sort of baggier, for want of a better phrase, and it can make it look a bit bigger. And actually, as we age, the bile duct becomes a little bit more baggy, for want of a better phrase. And so for each decade we live, the bile duct increases about 1 millimeter in size. So for some people, a slightly dilated or slightly swollen bile duct can be quite normal for them. And it's not always a sign of anything to worry about. But it is important, if it's been identified, that the doctor who's organized a scan is happy that they understand why it's dilated, because it would not be related to your PBC, not directly.
Yeah. I mean, Ursula was originally treated for gallstones anyway, wasn't it? And they happened to find this was helping with PBC. That's how the story. I mean, it's a long time ago now, but
it is. No, you're absolutely right, and this is why you should probably be sat in this seat. So I think it's Ursa was indeed developed to treat gallstones and to try and make them smaller. The evidence for its use in that regard actually has been pretty weak. We know obviously it can be a very, very effective therapy for some people with PBC.
Yeah, I remember when I was diagnosed 100 years ago, there was no Ursa then. I've been diagnosed about 33 years, I think, now, and it was about 2-3 years when Ursa came along, and it was a miracle drug, and I think it still is, actually, but there we go. Now, can OCA cause gallstones? Or beta-cholic acid, can it cause gallstones?
So probably. So I think if do we have studies to show that people who are taking OCA have more gallstones and more gallstone-related problems than the general population? I don't think we've got that data yet, but there are some studies which have looked at the way that beta-cholic acid changes bile acid metabolism, and that can make your bile a little bit less or more viscous, more sticky, in other words. And so there are some chemical changes that OCA will bring about within your bile that are associated with an increased risk of gallstone formation. So I think it would be entirely plausible that OCA can increase gallstones. But do I see a lot of people complaining of gallstone symptoms on OCA? No, I don't. At the same time, the total number of people treated in the UK with OCA is still relatively small, isn't it? So it might be one of those things where the risk of actually causing symptomatic gallstones is very, very small. And if the risk of that happening is very small, you're going to have many, many, many thousands of people treated with OCA before you start to see that significant effect. But can it plausibly cause gallstones? Yes, it can. But remember, PBC itself is associated with an increased risk of gallstones compared to other members of the population. And gallstones amongst females are also extremely common. And so this is what makes it quite difficult to tease, but whether that's been the specific cause in one individual. But from a biological plausibility standpoint, absolutely, yes, it can cause gallstones.
And diet's related to gallstones as well, isn't it, Andy?
Yeah, it's an interesting one. And I think we tend to think of diet. I think genetics are probably more important than diet per se, but obviously diets that are higher in fat might provide more substance for stones to form, for example. But particularly, we tend to find that high fat diets are ones that will tend to provoke attacks of gallstones, because essentially your gallbladder is a reservoir for bile, and bile is predominantly used to break down fat-soluble vitamins. And so when you have a meal that's high in fat, your gallbladder contracts to squirt a load of bile into your intestine to help your body break down those fats to extract the fat-soluble vitamins. And so a fat meal will make the gallbladder squeeze more, and if there's a stone that happens to be near the neck of that gallbladder and it can squeeze it to get stuck there, that's when you can get attacks of gallbladder colic. And so fatty meals can be very much precipitants of symptoms in people who have gallstones. But it's also important to remember that gallstones are really common in the general population, and the vast majority of people who have gallstones found on a scan never have any major problems from them. So we don't rush to take gallbladders out when we see stones. We would only do that if there are signs that the patient is experiencing gallbladder colic, or they're being jaundiced as a result of a stone popping out the gallbladder, getting stuck in the common bile duct.
Okay, that's quite interesting, isn't it? Nobody talks much about the gallbladder because it is a bit squidgy, but it's quite interesting what you're saying. So we're going on. If the ALP, which is the alkaline phosphatase, is showing an adequate response to URSO after 6 months. Now, I'm not sure what an adequate in this instant means, so we just have to go with a generalization. Do we still have to wait 12 months before being offered second-line treatment like elafibranor? Is there evidence I can share with my consultant to persuade them to start it sooner? Well, we don't have the exact detail here, but your thoughts would be really helpful, Andy.
So it's a really important question, and I think it'll become an even more important question as we use more of what we call the second-line therapies. So first-line therapy is ursodeoxycholic acid, as we've already alluded to. That, for many, many years, as you know, Collette, was the only drug. And you and I will remember there were days when people were very doubtful as to whether urso did anything in PBC. And
absolutely, yes.
There were some clinicians who wouldn't prescribe it because, oh, well, it doesn't do anything. But thankfully, we gathered the evidence over a period of time to show that it does have an impact. So at the moment, the licensing for second-line therapies is normally after a failure to not normalize, but to get your ALP, your alkaline phosphatase enzyme, under this threshold of 1.67 times the upper limit to normal after 12 months of therapy. So strictly speaking, according to the license of OCA, certainly within the UK or other second-line therapies, then it's 12 months. However, there's a tension then between, well, how long should we wait? Because we know that urso in some people can take up to 12 months to have full effect, but in reality, the bulk of the effect is seen at 6 months. So by the strict letter of the license and the way these drugs are funded and remunerated, it's 12 months currently. But there are some circumstances where we do try to flex around that. And those groups of patients, I think, would benefit particularly from earlier second-line therapy, although the guidance doesn't recommend this at this point in time because the evidence isn't yet there, are people who have got quite significant underlying liver disease. So that's what we call advanced fibrosis, scarring, or even cirrhosis. And people who have a very, very high ALP when you first present, because we know the higher your ALP is at first presentation with your condition, the harder it is to treat. Okay, and so we often have to look at how much it's come down, because in some people, if they're very nearly that threshold to be a responder at 6 months, then some people will, just with a little bit longer on the urso, get there, and they will reach a response criteria at 12 months. However, if you are miles off that threshold at 6 months, so say, for example, your ALP was 800 when you started, and we're aiming to get it around about the 200 mark, and at 6 months, it's only 500, it's not really going to come down to 200 at 6 more months. You're not going to expect it to improve dramatically. So to some extent, the trajectory, how quickly it has fallen and to what degree it's fallen at 6 months, can give you a reasonable indicator whether you're likely to not respond at 12 months. So what we do within our internal network locally is that if I've got somebody who is quite a long way off meeting the treatment threshold, or the response threshold rather, at 6 months, then I will start the process of applying for second line therapies and getting access to them, because I know that ERSO is not going to get that person to that criteria. At the same time, from an individual's clinician's point of view, the recommendations are that there might be limitations in their local area that it can only be issued according to license. So we are going slightly outside the license for many of these agents at the moment, but it makes sense to me to start earlier in those people who are really high ALPs and are quite a long way off the treatment response thresholds, because 6 more months isn't going to halve the ALP when it's only gone down by 10% in the first 6 months.
Yeah, being a numbers woman, even I get that. But is it fair to say as well that if you do go into second line therapy, that unless there's a good reason not to, that you stay on ERSO?
Absolutely. It's additional therapy, not instead of, because virtually all the patients in the second line treatment studies were also on ERSO, not exclusively, but the vast majority are. So it is really important. And these drugs work in different ways. So it's really important that you take both medications, because one doesn't replace the other in the way the drugs work. So therefore, you're potentially getting either an additive or what we call a multiplicative benefit, where the two drugs, so sometimes one drug will give you say a 30% improvement, the other one will give you a 50% improvement. Well, sometimes that just becomes a simply additive. But in some cases, if the drugs are working in completely different ways, you can sometimes get a multiplier effect where you get an even greater effect by using two drugs together than each in isolation.
That is really excellent to know, because from time to time we do hear of people taking off their ERSO, and then we can refer to people like yourself and say, well, we actually heard this straight from the expert's mouth, as you say. So I've got a question. Now, this question is about turmeric and various things, and I would say to everybody out there who talk about supplements, I know of no doctor on this earth who will comment on supplements. I'm going to ask you the question anyway, Andy. But the supplements you buy out of various health shops, to my knowledge, are not really that well tested, and we cannot expect our medical advisory board to comment on something they don't know the results of any test. So I'm going to read the question, and maybe you can make of it what you will. And it's basically they're asking, is it okay to take turmeric vitamin supplements daily for muscle aches? My hepatologist, now this bit we do need to address, my hepatologist, I shouldn't take muscle relaxation or pain medication. So I think we need to address the pain medication as a separate issue from the supplements.
Yeah. So supplements is such a broad field.
Yeah.
There are supplements and there are supplements. Okay, so some people are actually deficient in things that we don't readily measure. The commonest one in the general population is vitamin D. Okay, and this is really important when we're talking about liver health generally, because people with PBC, particularly if you've got quite significant PBC, you are going to have potentially poor bone health, and vitamin D is really important to maintain bone health. Now, NICE, which is the regulatory body for the UK, says that all of us should be taking vitamin D during the winter, and if you have darker skin, you should be taking it all year round and you live in the UK, because actually we don't get as much sunlight than you do in other countries. If you've got more melanin in your skin, you're not going to get as much vitamin D from getting out in the pathetic amount of sunlight that we have in the UK.
You Thailand and Scotland.
Right. Although you get longer days in summer, don't you? But,
we do, yeah.
So vitamin D is really important. So actually, if your supplement contains vitamin D and you're taking that through the winter or even through the summer, to be honest with you, as long as it's a standard therapeutic dose and not a high dose, there is no harm in that whatsoever. Some of the vitamins, vitamin A, for example, doesn't have any direct effect on your bones, can be used for skin issues, and it has other sort of properties, of course. Vitamin A, if you take loads of it, can be toxic to your liver. So even the normal, it's a really vital vitamin, but if you take too much vitamin A, it can cause liver failure. Now, you have to take a heck of a lot of it, but the point is that it can be toxic and dangerous. Then you go aside from the standard vitamins, and then you start looking at all these sort of herbal remedies that people sort of, they almost get labeled and promoted and badged as supplements, and they're not really supplements. These are chemicals that are purported by people to have certain effects, and some of them might do, but most of them don't, and some of them can be very, very dangerous for your liver. There are websites out there that can tell you whether a certain supplement has been associated with liver injury. But many of them have not been tested or not been used in enough people to really identify whether they are safe or not. So this is why, as doctors, because we use medications that have been extremely rigorously tested in clinical trials. And if anybody's ever worked on a clinical trial, they will know the degree of scrutiny that goes on with these trials. It's phenomenal. So these things are very tightly controlled. If you get so much as a cough or a cold or a sniff on a clinical trial, it gets recorded. It gets put in the product literature, which is why when you look at a paracetamol insert, it's got 400 different things associated with it. Doesn't mean to say that drug causes all those things, but those symptoms that have been reported in people taking that medication, and it may or may not be directly related to the medication, they are duty bound to report it. Lots of these supplements are not subject to the same standards, so they can hide, bury, not comment on the things that have been reported to occur with some of these things. So for me, I'm very relaxed if people come to me and saying, I want to take some vitamin D. I think that's fine. And it's low dose, no problem at all. A low dose iron, some people just get a general, even if they're not iron deficient, some people do get a general pick me up from that. Is it placebo? Is it genuine? Difficult to say in many people. But at the same time, if it's relatively cheap and we know it's safe for you to take because it's a medicinal product, albeit at a lower concentration, then we can be, generally speaking, I try to be flexible and try to be relaxed about that. My big worry with the supplement industry is that it is an industry. It is there to make a lot of money. Some of these supplements can be phenomenally expensive. And my worry is that people could be taking things which are potentially dangerous to their bodies, not just their livers. And secondly, it costing them a lot of money with really uncertain benefit. And I get it when you're suffering from symptoms and sometimes you don't get, maybe standard medicine isn't working for you. Maybe you're not getting a good response from physio, or long delays with this, that, the other. You're looking for answers, but very often you can end up spending a lot of money for things that are not going to do you any good. And in some cases can cause you harm. So coming back to the pain aspect, I think it's really important. Having a liver condition does not mean you can't take painkillers, but in certain circumstances with liver disease, there's certain ones to avoid. In general, we avoid non-steroidal drugs such as ibuprofen or diclofenac in people over the age of 65, not exclusively, but over the age of 65, there's a higher risk of GI ulceration and bleeding. If you have kidney disease or heart failure, it can cause more fluid retention. Same if you have advanced liver disease. And so if you have any significant health condition and you're older, then those non-steroidals can be more harmful for you. But paracetamol is a very effective entry-level painkiller for very many conditions. It is the safest painkiller in chronic liver disease by far. We always say to people, don't exceed 4 grams in a day. If you've got...
That's 24 hours, not a day, 24 hours.
24 hours, yeah.
Yeah.
And then occasionally your doctor might recommend you take no more than 3 grams per day if you've got a really severely damaged liver. But even then, even if it's at the most severe form of damage, you can still take 6 tablets or 3 grams in a 4-hour period. So in terms of other painkillers, then those tend to have to be prescribed. So we're talking about codeine or tramadol or morphine. Those drugs need to be prescribed because they have a greater side effect profile. And that means there's more potential consequences with your other conditions. So they need to be assessed and recommended by a healthcare professional. And so pain relief is really, really important. We see this time and again, don't we, Collette? You look at all the patient surveys, all the patient experience. Word cloud still sticks in my brain.
Oh, absolutely.
How strongly pain comes out in people living with PBC. And some of that's muscle pain. Some of that is due to associated rheumatoid conditions or Sjogren's. But at the same time, pain relief is really important in order to maintain health, vitality, physical exercise, and be a functioning human being. So I wouldn't say that you should take no for an answer when somebody says you can't have pain relief. You can. You just have to be a little bit more thoughtful about what pain relief you use if you have a liver condition. But in most cases, they can take most things.
Do you know, it's quite strange, Andy, because we know the history of paracetamol, if it's overdosed on anybody, whether they've got liver disease or not.
Yeah.
Now, I hear them quite a lot. My consultant says I can't take paracetamol. My doctor says I can't take paracetamol. So that's really excellent that you've clarified that really very well. So the answer is absolutely yes. And I'm one of these women, I fall from time to time. I had a broken scaphoid quite recently, and I broke a bone in my foot not long before that. And I can assure you, pain relief is essential. Anyway, so this is, you haven't seen this, Andy, so apologies, it came in very late. I don't know where this person lives, and perhaps I might pursue this. Perhaps we can pursue it together today, actually. I'm now in liver failure with ascites, portal hypertension, varices, weight loss, and this is after 28 years diagnosis. What is my life expectancy? And she has said, be honest. And then, thank you.
That's a really tough question, isn't it? And I'm really sorry that you're experiencing this, because it's a really difficult place to be when you've got serious liver disease like that, isn't it? And I'm sure you're not feeling well on a day-to-day basis. Living with ascites is difficult because you're carrying extra fluid around, your body's having to heat all that water, so it takes a load of your energy away when you've already got a condition like PBC, which starves your body of energy anyway, or makes you feel like the batteries have run out. I think prognostication in liver disease, as in many other chronic illnesses, is very variable, and it does depend on a number of factors. And this is a bit of fence sitting, but for good reason, because what I don't want to do is give you a false picture either way. I would say this will be a situation and a discussion that is definitely best had with your clinical team, because they have access to all the relevant information. So some people have fluid buildup, they have ascites, but actually in some people, if that is manageable, then the prognosis is very, very different than if it can't be managed. Mm-hmm. Similarly, the prognosis is very different if you have kidney problems, if you have severe jaundice, if your blood clotting is really poor. And all those things will have significant importance in terms of how severe this problem is for this person. And so only their local team will have that information. So I think this is one of the ones I very rarely sit this much on the fence, I think, Collette, but I think this would be inappropriate to comment in this forum without all that information.
Okay. Sorry, go on.
No, go on. I think it should definitely, this should be a discussion with you and your clinical team. Also, depending on the person's age, are they eligible for referral for liver transplantation? Because if they are, and generally speaking, this is a general rule, people are usually under the age of 70 to be eligible for that, but there's not a blanket rule on that. But this is why it needs to be discussed and considered by the local clinical team. Mm-hmm. Again, if transplantation is an option, that can be very, very different in terms of changing outlooks, can't it? We know how transformative transplantation can be. So there's so many things we don't know in this difficult situation. And I think it's really important, not just for this question, but for your ongoing care, that you have that communication with your local team, because you're going to need that ongoing communication, because they'll be providing care for you, whatever happens next, isn't it? So I think it's...
What troubles me about this, Andy, Robert and I could tell you, we could write a book actually on some of the stories we've received like this, and the person has been nowhere near a liver unit or a specialist centre or have been offered specialist care. And quite often we manage to direct people and get people to those hospitals where they need to be. but we don't know enough about this person. And you're actually quite right to sit on the fence. But I'm glad we had this question, Andy, because I want to open the conversation up to letting people know that it's important you get good specialist care. And for this person with this stage of the PBC, if you phone the office, the BBC Foundation office, you'll get my direct number and just call me and we'll talk through this and we'll look at where you are, what hospital you're attending. Let's see if we can get you sent somewhere else. We don't know a lot about you, but this maybe we can help. But I would say to anybody out there, and I'm sure Andy will agree with me, if you are told you're in late stage PBC, is absolutely essential that you're seen by a specialist centre. And if you want a list of those centres, they are on our website. There's 7 transplant centres in the UK, but there's also, I think there's 10 or 12 actually specialist centres. I think it's 12. But some people are left in little hospitals and in little towns that never get anywhere near the specialist, Andy. Sadly, too many still. So if I can invite that person to talk to me directly, you will get my personal number on the PBC helpline, BBC office. Is that reasonable, Andy, to take that forward?
I think that's the most appropriate way forward, isn't it? And I think, it's really brave of this person to reach out in this forum like that. And as I said, I know you, Collette, and I knew you'd be offering that before you even said it. But that was for you to say, not me. But I think that is definitely the more appropriate way forward. And I know you come to the likes of me and other medical advisors to ask specific questions about, is this reasonable? Is that reasonable? So we're not able to say to directly steer your care, and it would be inappropriate to give you a prognostic conversation in an open forum without all the relevant information.
Absolutely.
But it's about, understanding where you're at, what you're currently receiving, are there other options, and how you can. And again, part of this, and the PBC Foundation has done loads of great work in this, around preparing for outpatient appointments, but also about how to navigate systems in terms of what are the right questions to ask. And we can help facilitate you asking the right questions so that you get the answers that you need. Some of those you will kind of know yourself, but others, sometimes it's about asking them in a slightly different way, or asking a slightly, indirect.
Yeah, that's right. And we can coach people through it. It's not been unknown, Robert, more than me, to attend a hospital with somebody. And it's worked. But I would urge this person, and thank you for getting in touch. But let's just see what we can do, and don't give up. We're not finished yet, okay? So, right, here's another interesting one, Andy. So this person's travelling to South Africa, to Botswana and Zimbabwe in January. So they've gone onto the government website, about inoculations. Is there anything else they should consider with PBC? I remember in the old days, when I was first diagnosed, I was told I couldn't go to countries where there was yellow fever. But like I say, that was forever ago. But is there anything in particular this person should be thinking about by way of inoculations?
No, I mean, I think, if you look at the Foreign Office sites are very updated with what the current infectious agents are in the countries that you're traveling to. And there's been a very strong recommendation from public health teams about what are the appropriate vaccinations to have. So the only thing to sort of slightly say is that depending on severity of your liver disease, if you have more advanced liver disease, there are certain vaccinations, or if you are immunosuppressed as a consequence of your liver disease, sometimes live vaccines can be a bit more, you have to be a bit more cautious with them than the inactivated.
So what would you describe as a live vaccine, for example?
Well, they're all very different because, for example, some of the flu vaccines, some years, some brands or some delivery are inactivated and some are live.
Really? Okay.
So a live vaccine is essentially a vaccine that contains a small portion of the active.
Like tuberculosis.
Yeah. Okay. So as opposed to an inactivated vaccine, it's essentially a protein of that virus bacterium that triggers the immune system to form antibodies against it. So in the vast majority of cases, vast majority of cases, it's absolutely fine.
Yeah.
But if you've been told you have advanced liver disease cirrhosis, just double check with your medical team who will have access to your most recent bloods records to say, is it okay for me to travel here with this particular thing? And I would say in the vast majority of cases, it will be absolutely fine as long as you adhere to the Foreign Office schedules and those vaccinations. But just that's the only slight caveat, is just to be aware that if you've been diagnosed with cirrhosis, just to be extra careful because you don't want to get caught out.
That's great. Good advice. Now, I've got a medication here that I won't be able to pronounce very well. Montelukast, Montelukast. It's for asthma.
Perfect. Yeah.
Okay. It states it causes liver injury. Thoughts? They all do, don't they? Just not belt and braces from the legal teams.
Yeah, a little bit. As I alluded to earlier, because the way drugs are developed in clinical trials, the amount of surveillance, every single thing is captured. So if somebody has an episode of abnormal liver tests from some other reason, it gets captured in those logs, and it'll often end up in the package insert. So lots of drugs can cause drug reactions. Most of them don't. Even the ones that are very common, in inverted commas, to cause drug reactions still don't in 99% plus of people. Yeah. They're not sort of inevitable. Most drug reactions of the liver are what we call an idiosyncratic reaction. So your immune system, for whatever reason, just reacts against the drug, and it creates a reaction within your liver. I would say we see lots of people on Montelukast. I don't remember the last time I ever asked anybody to stop that drug as a result of drug-induced liver injury. What we usually say is, if you've developed a change in your liver blood tests on a new medication, the first thing you always look at is, could it be that medication that's done that? So yes, it's in the product insert that it potentially can. It's not a particularly high risk. It's not one of the classical drugs that causes drug-induced liver injury, but it's not impossible. But I think if you're taking the medication, your liver tests are stable, then there's no harm in carrying on taking it, and you can just carry on.
Excellent, good. Here, well, we've kind of covered this, but I'll read it out anyway. Is it okay to take codeine or paracetamol when you have PBC?
Yeah, definitely. I think the one thing I would say with codeine, so codeine and morphine drugs, they can cause itching. Okay.
Yes. Confessions of a. Oh, there was a book that explained, but an opiate. Confessions of an opiate.
Alex, is it? I didn't. Yeah, I'm not familiar with that book, but
yeah, no. James Newberger told me about it, so I had to read it. Do as I'm told. And it was about drugs, and
we'd all do as what we're told if James tells us to do, wouldn't we? I mean, why wouldn't you? You'd be crazy not to, wouldn't you? And I mean that sincerely. Yes, so I mean, morphine, particularly intravenously, definitely causes itching, but so oral morphine can. And don't forget, codeine is an opiate-based drug. Okay, so again, if you haven't got advanced liver disease, codeine is generally safe for the most part. But just be aware, if you do take it and you're getting increasing itching symptoms, just think about that potential link between the drug potentially causing itching or making it worse for you. But for the vast majority of people, if clinically indicated and simple painkillers like paracetamol aren't working, and if non-steroidals aren't for you for other medical reasons, then codeine is a commonly used painkiller, and it can be very, very effective for people, but just be aware that it can cause itch.
Yeah, that's actually a very, very good point. Confessions of an opiate eater, that's what it was. So what do we know about cholestyramine and its effect on ALP?
Yeah, well, not a huge amount really, in the sense that we don't think it really has any major impact on your ALP. So remember, the ALP is a consequence of the bile not being able to get out of your liver. Okay, cholestyramine is not a drug that makes your PBC better. Cholestyramine is a drug that binds bile salts in the gut. So they already have to have got out of your liver into the gut before the cholestyramine can have an effect. And so therefore, it's not going to improve what's happening within the liver because it's not working in the liver. It's working solely in the gut. What seems to happen for some people with itching from not just PBC, but other what we call cholestatic disorders, PSC is another one, is that bile salts get recirculated in the body. So they get excreted down into the intestine, get absorbed in the intestine, then resent back to the liver. So the rationale behind cholestyramine is if you can bind those ones that do get excreted into the bowel and you're reducing the pool of bile acids in the body, then if less of those are recirculating back to the liver, there might be less for, in terms of itching. So it's really an itch treatment rather than a PBC treatment, and it doesn't in the liver, it works in the gut.
That's all our questions. I would like to say, if we've got a wee bit of time, are you okay to chat about, which is I'm always banging on about, is diet, not so much diet, but what we eat, movement is medicine, drinking lots of water. A lot of people come on the phone to me, as you know, I still do the helplines, which is, it's a joy for me. I love speaking to people with PBC. And there seems to be very little by way of advice, but doctors are busy about, diet, and they'll say, I'll just eat healthily and what have you. But I hear more and more and more the effects of sugar-related food. And as you know, Andy, there's a lot of food that's got hidden sugars in it. And so I just want to run this past you. I encourage people to really look at what they're eating, and processed food in particular. And I know, it's tired when you're tired with PBC, and the last thing you can do is be bothered cooking. But sometimes making a great big pot of soup, and there's easy ways of doing things. But we're hearing more and more anecdotal evidence about sugar-based foods, processed foods. It does seem to make a difference to people's energy levels.
Yeah, I think the reason why we're so reticent in clinics to sort of address this is, one, most of us don't have any formal training in clinical nutrition.
No.
So that's problem number one.
It wasn't a complaint, by the way. It wasn't a complaint.
But it's entirely valid point, okay? Because I ask this question a lot in clinic myself. So most of us don't receive any formal training in clinical nutrition. Second of all, we don't know what the optimal diets are in most conditions. So it does fall into the very generic type category. But I think what is fair to say is that we are increasingly seeing more and more health problems, both related to weight gain through ultra-processed foods and high-calorie diets, but also changes in the gut microbiome. So that's basically the constituents of your healthy versus unhealthy bacteria in your gut. And huge amounts of your feces is bacteria. Okay, there's billions upon billions of bacteria in your bowel at any one time, and they're in a complex state of interplay, talking to one another. There's the good ones will dominate, and there's diurnal variations. They'll change over the days. Sometimes one will come forward and make you ill, and you can get your bacteria into your bloodstream and all these sorts of complicated things. So the old phrase, you are what you eat, actually is increasingly true.
Yeah, I agree with that. Yeah.
Certain ultra-processed diets and certainly high refined sugar diets are changing the way our good and bad bacteria are balanced out in our gut. And that could be unhealthy for us. We start to learn more about how that impacts us from a cardiovascular disease point of view.
Yeah.
Lots of studies about potential cancer risk from all those sorts of things, because your immune system is a key player in reducing your risk of cancer. What does it mean for immune disorders? Well, we haven't quite teased it out yet, but for some disorders, it probably will have a massive role to play in terms of how it triggers your immune system or how your immune system behaves. Could it be the trigger for an autoimmune disorder like PBC in some people? It's not beyond the realms of possibility, So thinking about what you eat is really important about trying to maintain energy, vitality. And you think that something high in sugar would automatically be better for your energy, wouldn't you? But actually, refined sugars, not so. So what you want is, you do need that good mix of carbohydrates, proteins, and a little bit less fats. Fat's not necessarily always a great idea, particularly if you've got gallstones we spoke about earlier. Fats also make your gut sluggish. Okay, so a diet that's high in fat slow your gut function down. Okay, so if you're liable because you've got PBC and you can't move around as much because of your fatigue, or if you've got Sjogren's joint pains, having a high fat diet then is just going to slow your gut down, and you're going to get quite constipated. You're going to get quite congested. You'll have lots of abdominal pain. You get lots of bloating. So there's really good reasons to be trying to avoid ultra processed foods, ultra sugary foods, and try to focus wherever you can on home cooked food where you've got control over what you're eating, because even the low calorie ready meals are packed full of calories compared to what you can cook at home.
Yeah.
So that's not to say it's easy, It is a challenge, and we all lapse when we're busy or when we're feeling fatigued, under the weather. But actually, it can have direct impacts on your general vitality, energy utilization. It can have direct impacts on preventing weight gain or helping support weight loss. So things that can assist if fatigue is a big issue for you. It's not going to fix it for you, but it can help make it a bit better. It can help your mobility, and we know that there's that virtuous, positive feedback loop, isn't it? Whereby if you're not so mobile, you're feeling unwell, you're fatigued, you gain weight, you get less mobile,
cycle,
gain weight, less mobile, fatigue, and so trying to break those cycles, as hard as they are, be a positive feedback cycle instead of a negative one, where you can actually make some significant gains. And although your fatigue won't be, it won't vanish, it will hopefully be more manageable for you because you'll have energy on a day-to-day basis. So absolutely.
There's a nice wee simple things like some banana on toast. You don't need butter on it, or sardines on it. There's nice wee simple things you can have if you're living on your own and you're older and what have you. You don't know what to do other than the ready-made meals. But I do think, and I hear from people, the difference when sugar, refined or not, or hidden sugars, when that's dropped out of the diet. And the other thing I would say to you is water. I mean, I go through pints of these things every day. Quite often I speak to people and they're dehydrated, but they don't know it. And I'll ask them how much water they drink in a day. And we're very lucky where we live, you and I, Andy, because we've got nice water. But they'll say, well, drink tea. And it's just not enough. You need hydrated. It does help your energy levels.
Yeah, it does. Tea and coffee has caffeine. Caffeine is a diuretic, so it makes you lose water as well as the water you're taking in. So you pee more when you drink those drinks. The other thing I always say as well is that when I talk to people about their calorie intake is look at where you've got wasted calories. Okay, so energy drinks, fizzy drinks, sugary drinks are wasted calories. There's no nutritional value in any of those things. So if you're going to eat things you want to eat the things that you get real enjoyment out of, rather than having lots of wasted calories in those things. Stick to water. Water is actually quite good at filling you up as well. You feel fuller if you drink water. So that actually, if you look at people who drink a lot of water, one of the reasons that personal trainers, people that will recommend you drinking a lot of water is partly to stay hydrated, but partly it actually tells your brain that you're full, and so you don't eat as much. Because a lot of what we think of as being hungry is a stomach that's just got some space in there. So fill it with some liquid and that's got no calories in it at all. You'll be better hydrated for it. It might help with mental alertness and minimizing, certainly sort of concentration fatigue, etc. But again, it might just minimize your calorie intake, so you can focus your calories on the things that you really enjoy eating.
And it rehydrates the skin. I'm going to be 90 next year, but you would never know, would you? Right, we've had a fabulous session today. We've covered quite a lot, Andy, and thank you for indulging me at the end. I do like to cover just some of the everyday living matters for our people. I think it's really important. There's so much to PBC, isn't there? We really are a lovely bunch of people. But your time's been, we've got messages saying thank you. Thank you so much, Andy.